next chapter is going to cover pain, temperature regulation, sleep, and sensory functions. Okay, the first part of this discussion is going to be on pain. And pain basically is any unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is whatever the experiencing person says it is, existing whether he says it does. Okay? Which is really kind of an important thing. Okay? It's such a simple statement, it seems kind of obvious, but a lot of us will actually take somebody and look at them and they'll say to us and they're having severe pain, and you'll just say, they're not really having pain, and you'll walk away. Okay? If that patient's really saying that they're having pain, our primary job is to take care of it. Now, if they're a drug seeker and they have other problems, does that mean that their pain is less? And the answer is no. And our job is, again, not to take their social situation and putting it into a situation where we don't give them the right medications. Okay? You're not going to reverse a narcotic abuser while they're in the hospital. It's a long-term management problem, but you've got to manage their pain. Okay? If you have somebody who's been on opiates for a long period of time, or has been on heroin or something else, and then they have an operation, their pain levels are going to be unbelievable. Okay? Their receptors are so downregulated that when you do give them opiates, it doesn't seem to work. And you'll be like, I can't believe anybody can actually tolerate this. And you'll be giving 40 milligrams of morphine. Something like that would kill most people. Okay, I saw that done the other day. We actually gave somebody 40 milligrams of morphine before we actually got them halfway settled down. Okay? This person was doing a lot of street drugs, but at that point, what are you going to do? You're going to not give them enough? That's not the right thing to do. You want to make sure that the person stays as comfortable as you can, and that requires higher doses. You take care of that, and then send them to rehab after they're done. Now, there's different kinds of pain theories that hold true over the last few years. And there's things like the specificity theory, which accounts for the pains related to the amount of tissue damage. Okay? That accounts for many types of injuries, but it does not explain the psychological contributions. You can see people that can tolerate different levels of pain. Okay? People can actually do things that would amaze you, that they're having severe tissue damage, and they still continue to do it because they know they need to. Okay, so sometimes pain can actually be shut down in certain psychological conditions. Okay, now how that actually is regulated is a thing called gate theory. Okay, gate theory came about because specificity theory couldn't account for how people could suppress pain levels that should have been completely impairing, in the sense that they shouldn't be able to do what they were doing. Gate theory basically tries to explain that there's systems in place in your spinal cord as well as your thalamus that they can inhibit the sensory input and basically shut down the system before it's even perceived as painful. Okay? Now, when you're looking at pain, you can get nociception, which is the perception of pain, can be activated by many different kinds of stimulations. Okay? The stimulations can be heat, can actually be direct tissue damage, could they be also from release of neurotransmitters such as bradykinin, serotonin, hydrogen ion concentration increases, lipids, heat, pressure. All these things can actually send afferents via these actual afferent nerve endings all the way back to the actual nerve body located in the dorsal horns. Okay, so that is the area back here, and dorsal horns of the spinal cord. So this information is brought all the way back. Eventually that information then travels, depending on which kind of sensory information, if it's pain or temperature or touch or soft touch, those go into different kinds of tracks back to the brain. Now the nociceptors can be bare nerve endings in skin, muscle, joints, arteries, and viscera that respond to chemicals, mechanical, or thermal stimuli. So there's many kinds of activators of these nerve endings. They're able to detect a wide range of stimulation, and there's different kinds of these nociceptors. Okay? Unfortunately, that means that we have a hard time knocking out all of these kind of nociceptors completely, and that's why sometimes local anesthetic infiltration will not work perfectly. The person will still perceive some level of discomfort with even local infiltration around these nerve endings. Okay? So the actual types of nociceptors can also show different levels of sensitivity to local anesthetics because they have different sensitivities in the sense of how the channels are being used. Remember, local anesthetics are using inhibition of sodium channels to cause their effect. So if you have nociceptors that are being activated by potassium, calcium channels, then you're still going to perceive discomfort. Okay? Now, the most important of these voltage-gated receptors that propagate the nerve signal down the road, of course, is sodium. Okay, it's not, but the actual activator itself may be these three other different receptors. But the sodium receptors are really responsible for propagation of signal down the axon. There's 7 other transmembrane receptors called transient receptor potential channels, and that also is important because that makes it more complex, which makes it more difficult to effectively knock out those nerve endings completely to get the effect that you would desire. Okay? And the distribution of nerve endings varies throughout the body. And if you look at somebody's sensory distribution for afferent painful stimulation, the hands and the lip have a very dense sensory perception level, versus the back of your back has a low perception levels. Okay? And so different portions of your body have different responsibilities for afferent information being sent back to the body. That is accounted for what is called the homunculus. Okay? This is a representation based on surface area of how the afferent information is coming back to the brain. Okay? It's not just an artistic rendering, it's actually a percentage rendering of the body based on how much nerve endings you have in different locations. From this picture, you can see that the hands take up a very big part of the sensory perception of the world. The secondary information source is your lips and your tongue, okay, which accounts for why you're able to sense things on your lips very sensitively. If you ever had a cut on your lip, you can feel it it's exquisitely tender, simply because you have the number of receptors are much higher in that level. You can see the rest of the body has a much lower sensory level. Okay, so body can change its density based on its different needs. If you have an amputee that's young, you can actually change the sensory perception more to the feet. Some children that are born with no hands, they actually have tremendous sensory perception to the legs and the lower feet, and as a consequence, they can actually use their feet just like hands. So it depends on, of course, the plasticity of the brain and exposure. Now, one of the important things to understand is these nerve endings basically act like little miniature minefields. If you look at this, just imagine this is your back, okay? And the actual minefields, if you don't touch them with a needle, you cannot cause pain. So you've all seen this. We've done clinical work, and you've injected somebody IM in the butt. You've seen every once in a while that person doesn't hurt at all. If you wondered why, you wonder why you just gave an injection one time and one person's screaming in pain and the other person's not feeling anything. Okay? The reason being is when you're putting your needle in, if you're having no pain, you're hitting in this area. Okay, so you're hitting in between. And that's why they teach you in clinical to go at 90 degrees to the skin. So when you're putting your needle in, you should go completely straight in. Okay, they never teach you to go at an angle. Okay, why do they teach you not to go at an angle? Because when you do that, clinically, it feels a lot, most people complain of more pain. If you're coming at an angle, what you're doing is you're taking that needle and watch what happens when I come at an angle. You think that's going to be a lot more painful than hitting one? Absolutely. The more nociceptors you hit, the more painful it is. So one of the things that I want you to learn is from this lecture is that please, when you come at somebody's skin, make sure that you're perpendicular to the skin when you're coming at 90 degrees to the skin. The needle should be going straight at that person, okay, when you enter initially. It's a lot less painful. Okay, if you get lucky and you're in between the nerve endings, the person will not perceive any pain at all. Okay? The next thing is after you're in the skin, you then take around 3 cc's of local and inject. Okay? It takes 3 cc's of local for it to work and knock out the nerve surrounding. Okay, so that's why when you put the bigger needle afterwards, it actually works. The other important factor is that it takes time for the local anesthetic to infiltrate into the nociceptors and shut them down. It takes approximately 30 seconds. How many times have you seen somebody do a spinal anesthetic in the ER from somebody who's really ill, okay, and they put the person on the side, and they put the needle into the local, and the person will only inject 1.5 cc's. Okay, that's a big mistake, first of all. And then the next big mistake, you'll see the person immediately follow the spinal needle and immediately jam it into somebody's back, and they wonder why the patient's screaming in pain. It's bad form, it's not understanding how the medication works, and it just hurts a person unnecessarily. Okay, and as a consequence, spinals have this bad rap for being very painful. If you do a proper spinal anesthetic with a good local infiltration, the patient almost feels nothing. And as soon as you do it, the person looks at you, that's it? And you do it like, yeah, that's it. You know, and you think about all the horror stories you've heard in the past, and it's simply because people weren't taught properly how to do a good anesthetic. Okay? So the first thing you do is when you inject anything locally, and you want that area to be numb, is you inject 3 cc's of the local anesthetic. Okay? Usually it's 1% lidocaine or 1.5% lidocaine with epinephrine. Okay? Followed by waiting 30 seconds. And that's the hardest part, because you're going to go like, God, 30 seconds is a long time. And you look at your watch, it seems like forever. If you do that, though, what you'll have is somebody who will not move on you, and the patient will actually be much more comfortable, and you'll be able to direct them exactly what to do to help you do the procedure better. Okay, so it's worth the extra 30 seconds. Okay, so try to remember this lecture. I'm sure most of you forget it, because when I get to clinical, everybody's trying to move the needle around and doing these fanning techniques, and say, you don't have to do that. Fanning is for a completely different kind of procedure. We are putting needle after needle in the same spot. Fanning is to do with surgical procedures, which are trying to give a wide local area of infiltration. It's a different ballgame. You're not doing that. Okay? Pain pathways are classified based on the types of information that are processed. Okay, you have pressure, then you have penetrating or cutting damage, you have stretch, temperature, local inflammatory response, and ischemia. The properties of the axons can be considered the alpha fibers. They're lightly myelinated, medium-sized fibers that carry well-localized pain information, and they have rapid, fast response. Okay, the alpha fibers are very quick, and they go up usually via temperature and pain temperature, and bind to the afferents, and then they send the secondary fibers up via spinal thalamic tract to the thalamus, and eventually goes to the cortex. The unmyelinated C fibers, on the other hand, are much more diffuse, causing burning or aching sensation, and have a very slow response time. C fibers are the ones that give us the most difficulty when we're doing anesthetics, because they're sometimes very difficult to knock out completely. If you're doing a regional block, it's actually fairly easy because they're unmyelinated fibers, so it doesn't take very much. But when you're doing like an epidural, sometimes the C fibers, because they're so diffusely distributed, will give you a much more difficult time completely knocking them out. Now, the primary sensory neurons go up the dorsal root ganglia, okay, which is, remember, the posterior portion of the spinal cord. These alpha fibers come in, as well as unmyelinated C polymodal fibers, and they reach in and touch the dorsal root ganglia. Okay? When you look at the dorsal root, what we're looking at here is this kind of drawing. Okay. The afferents are coming in this direction. And then what we do is we break up this upper portion into what's called lamina. Okay. This is all laminas here, sorry. Okay. And the lamina, the important for us is lamina 2. Okay. Lamina 2 is where the sensory pain fibers are coming in, and then they connect. So they have a neurotransmitter release at that point, okay? And they cause an interneuron to send the signal either directly to the motor neuron to cause a reflex activation, or it sends other interneurons other places to propagate the signal up to the brain to sense it. Okay, remember, the actual spinal cord has two functions. It has a function to do reflex work, so it can move your foot away from damage, okay? Or it also sends information to the brain to process the information to know that you stepped on a nail. But before you know that you stepped on a nail, your foot's already off the nail. That's a reflex action. Okay? So that interneuron is important to send that kind of information on, so you get a reflex action. Okay? Now, this lamina 2 is critically important because it actually can also be an area of suppression. You can actually inhibit the sensory information so it never gets to the brain, okay, or significantly suppress it. So let's say you say to yourself, look, I need to walk across these coals because I got a saber-toothed tiger that's going to have me for lunch. I know it's going to hurt, but I got to still walk across this. Okay, so I force my brain to say, okay, I'm going to walk across this coals even if it hurts, and you run across, knowing that you're burning yourself, but you're still making it across. Okay, the reason you're able to do that is because you're able to inhibit two areas. You inhibit the thalamus, okay, which is the first sensory input besides the spinal cord, and the next sensory input that gets into the brain, which is the thalamic area. So your emotional levels is suppressing it at that level. And the first other place you can also shut it down is in lamina 2. Okay? So lamina 2 is also called substantia gelatinosa. Okay, so it's considered the main pain gate. And when they ask you on your boards what area of the spinal cord is responsible for the gate theory, and the answer is dorsal, is lamina 2 in the dorsal horn. Okay? This is another nice drawing showing you these pain fibers, how they originate via these C fibers as well as alpha delta fibers, okay, and how they actually reach into these inner neurons located in lamina 2, and how they actually then ascend to different sections of the spinal cord or up in the thalamic or the brainstem area. Okay, so it shows you how extensive these inner neuron connections are and how these different lamina are responsible for sending different information to different areas. Okay? This is just a nice representation for you to see it. Now, there's the second order neurons originating from the lamina. There's three classes found. There's projection cells that carry the information directly to the brain. There's excitatory inner neurons that relay information to projection cells or motor neurons or other inner neurons. Okay, so I'm sorry, this should have been shifted over when you're looking at this. This should be shifted over by 1. Okay. So it relays information to projection cells, motor neurons, and other inner neurons. And there's also an inhibitory inner neuron, which is what I was telling you about, which modulates a neurosusceptive response and basically depresses it when needed. Okay? The actual mu receptors bind here. Okay? Mu receptors activate these inhibitory interneurons to suppress the system and shut it down. Okay? Now the axons that are sent up via these fibers is usually via the spinothalamic tract, where it basically terminates in the thalamus, and then the thalamus sends a secondary afferent information up to the posterior portion of the parietal lobe, okay, of the postcentral gyrus. Okay, and this shows you a picture of what this system is set up. You can see the A delta fibers and C fibers are the first order neurons. They bind to the lamina 2, and then sends the second order neurons, which are the inner neurons, and send the information up the thalamus. And then the third order neurons then go from the thalamus to the actual somatosensory cortex or the postcentral gyrus. Okay, so it shows you there's 3 steps before you actually are able to get to the brain, okay, and be able to sense it and be aware of it. Now, anything that suppresses this information along the route, it means that there's decreased pain levels that are getting there. Okay? If you have an area that causes more pain than the other, the body will only make you aware of the area that you're having severe pain in. You've seen this in people that are injured and traumatically injured patients, or even in yourself. You've been injured. If you've been, like I have a broken arm, it really hurts in the arm, and you're not paying attention that you have a big laceration in your thigh. Okay, you can see this in surgery as well. You see a patient who's had a big abdominal procedure done, and they're not really paying attention because they have a good epidural in place and they're having no pain, and their only complaint is the NG tube that's severely painful, that's, you know, they can't tolerate. You know, when you're looking at the pain levels compared to the two different sources, a big incision, no pain, versus the NG tube is completely out of control on them. So people have different expectations in different situations. The third order neurons originate from 3 areas. They originate from the thalamic area, which is by far the most important. They also have second motor neurons that do go to the brainstem because it also activates the reticular activating system. So that would be an important system to wake you up in case something bit you while you were sleeping. And then you also your midbrain. So brainstem and midbrain, the same thing. So different responsibilities. It goes to the cerebral cortex, in the reticular and limbic regions where it's processed to actually decide what to do with the information. The pathways of nociception could be either through the spinal thalamic tracts, and there's other forms of pathways as well, which we'll talk about here in a minute. Now, neuromodulation of pain is, you can actually inhibit information that's going through gate lamina 2. We'll actually begin to suppress this. That's how we actually give our local anesthetics. When we're looking at spinals as well as epidurals, spinals will tend to bind to the spinal cord, but they selectively tend to pick out the nerve roots before they go into the lamina. Epidurals almost completely pick out only the nerve roots, so it doesn't really affect the lamina. Some of the drugs, which are the lipid-soluble opiates, will penetrate directly into the CSF and bind directly to lamina 2, inhibiting its function. So neuromodulators, such as opiates, can actually also suppress the system very effectively. That's why we give people Duromorph, which is a long-acting narcotic that we're giving into the CSF, because it binds very tightly to these receptors and suppresses the lamina 2. Okay? There's also integration of peripheral sensory axon terminals and spinal interneurons, which all hopefully can be suppressed to a certain degree. We're still trying to learn how to do this properly. We actually can use TENS units is what we're using as well. TENS units are a transdermal electrical modulation, okay? Neuromodulation, neurostimulation, which basically sends electrical signal at a certain frequency, and then it basically causes the inhibitory neurons to be activated and suppresses lamina 2 information. So TENS units can be effective also for neuromodulating the pain response downwards and making people a little bit more comfortable. Okay? It doesn't completely suppress the system, but it helps quite a bit in people that are in chronic pain. Okay? All this afferent information is converging on the spinal and dorsal horns, so if you can inhibit the information getting there, it's very important. Okay? This shows you a nice picture of how the noxious stimuli do arrive at the afferent, at the dorsal horns, and how the information then travels up and affects the different systems. The chemicals and neurotransmitters that are responsible for these neurotransmitters at these interneurons can be pain excitatory or pain inhibitory. Okay? The modulators of pain can be direct excitation through threshold depolarization from direct stimulation, or via indirect excitation. Threshold depolarization from inflammatory mediators can also take place. So inflammation of the noxious at the nerve endings can also be an inflammatory mediated reaction. Which if you think about it, when you see somebody who has a lot of swelling, they complain usually of a lot of pain. And that's because the inflammatory mediators are causing the discomfort. Okay? So it's not just direct stimulation, it could just be the inflammatory mediators. The excitatory neurotransmitters, by far, one of the more important ones is glutamate. Okay? Glutamate is also responsible for what's called NMDA receptor activation. Okay? NMDA receptors have been found to be very, very important in long-term potentiation of pain information. Okay? We know that in somebody who's chronically ill, or not chronically ill, but chronically using narcotics, their NMDA receptors can be severely downregulated. Okay? And that's why it counts for these very high, you don't see the effect that you want to see. Okay, we do know that NMDA is very effective at causing excitation, but also it does, if you don't have enough of them, there's nothing to block. Okay, so the mu receptors can't be blocked. Okay. There's other pain excitatory neurotransmitters like aspartate, tachykinins, and things like calcitonin, somatostatin, cholecystining. Okay, all these are possible pain excitatory neurotransmitters. The reason I sort of mentioned these to you on the side is that, you know, these are things that may be coming down the pike in the next 20 years. So you might end up hearing about NMDA receptors. You hear about this all the time in the sense that patients that are chronically abusing narcotics, that we can actually upregulate the NMDA receptor and get a better effect. Things like ketamine will actually increase NMDA receptors. And one of the things that we do now to actually shut down somebody who's having a lot of pain post-op is we'll give ketamine to them on emergence, so the narcotics actually work. So then it has a receptor that's upregulated. So now the mu receptor can actually shut down this excitatory stimulus. Okay. The pain inhibitory things that account for is the GABA. GABA binds to neurons containing substance P and leads to neuronal quiescence. So GABA agonists would appear to have some kind of pain control, but when we're talking about GABA agonists, we're talking about the ones that are up in the brain, which are basically not really responsible for pain at that level. If we can actually find GABA agonists that specifically can bind at the spinal cord level, we'd have an effect, but we don't have that really works. So all the propofol and all the benzodiazepines that are purely GABA agonists, they have no pain response at all. Okay? They're not specific to the ones that are located in the spinal cord. They only bind to the ones up in the brainstem. So there's different forms of GABA receptors. Okay? So please don't take that away. GABA agents, GABA agonists that we use basically do not suppress pain at all. Okay? Descending pain modulators such as norepinephrine alpha-2 receptors can be very effective in decreasing the actual pain response. And we use that with things like clonidine. Clonidine can be very effective in helping a long-term pain regulation. Serotonin is also very important in pain modulation in the medulla and the pons area. And then opiates, of course, are the pain regulations in the spinal cord and the brain. See, there's slightly different kinds of receptors. Endorphins, enkephalins, dynomorphins, endorphins, all these are endomorphins are all sort of related to opiates. What makes this plant so powerful is that it's mimicked what's endogenously found in our brain system or spinal cord system of releasing these endogenous opiates. Okay, this plant, which is we call opium plants, basically just copies the same kind of neurotransmitter that's usually used to inhibit pain response. Okay. How long has morphine been known to exist? Do you know? Very good. About 3,000 years. Okay. And guess who's been responsible for producing most of the opium for 3,000 years? Very good, Afghanistan. And you think that we're going to stop it now after being there for only 10 years. What a joke. Okay? It's just a joke. It's just not going to stop. Okay? That's their only primary plant that they use for selling. And they've sold it to the world for almost 3,000 years. You don't have to believe me. Go back and look at some of the Roman frescoes. Okay? You can actually see that some of the women were using opium even then. Okay? So this is a problem that's been an ongoing problem. And opium it's been always found in very high concentrations in Afghanistan. That's the reason everybody fights for Afghanistan since World War I. Did you guys know that either? Why the British cared about Afghanistan? Because they knew if they could control the opium, they could control who was going to have pain during the war. If you have soldiers who are not going to get any opium for their gunshot wound, you think they're going to be willing to fight? And the answer most likely is not. So if you can control the opium trade, you can control to a certain degree how the morale of the people are going to fight. The way the Germans got around it was they produced a medication called Demerol. Okay? Demerol is actually a perfect synthetic narcotic because it's got incorporated into something unique. Morphine has a side effect that if you give it to somebody who's in shock, it makes their heart rate slow down further and puts them into more profound shock and causes death more rapidly. Okay? So what the Germans did they knew that response. They understood medications pretty well. So they incorporated into their synthetic narcotic, which is normopiridine, atropine. So Demerol is the only narcotic that you can give that can actually increase the heart rate. And that's very helpful to you. Okay? Because if you have somebody in a recovery room that's having a lot of pain, but his heart rate's 45, you can give them Demerol, and they'll get their pain levels controlled quickly, and it actually will accelerate the heart rate for you. Okay? And the Germans knew that back in World War I. They stopped because they knew the British controlled all Afghanistan. Okay, so again, sometimes people don't see the historical associations. The endorphins response that you see here is the pain receptors, of course, go through these interneurons. You can see how these interneurons can be very important. If you can find a way to suppress them, you can basically stop all the response going back to the brain. And that's essentially what we do when we do spinals and epidurals. We're basically inhibiting either the nerve root, this is where the primary site of action for our spinals and epidurals, especially only spinal. Epidurals are almost all uniquely at the root level. The spinal will affect two areas. It'll affect these two areas because it's a little deeper, it's in the fluid state, so the local anesthetic can bind partially into the spinal cord and knock out the nerve root plus portions of the afferent tree. Okay? So it takes a lot less volume to get a spinal to work compared to an epidural. Now, the clinical description of pain can be the pain threshold point at which the pain is actually perceived as painful. Some degrees of discomfort can be perceived as pleasurable by some people. Other people will consider it extremely painful. So again, it depends on the person's perception. There's also what's called perceptual dominance. Okay? And this is a great technique if you're having dentist visits, okay, and you don't want to have local anesthetics put into you. I've seen this done by people. What you do is you take your thumb and you take your ungual area and squeeze it real hard, and that induces very severe pain. The police actually do this as well. These MPs did when we were kids to stop you from doing anything stupid. They grab your thumb and squeeze it real hard, and you'd go to ground pretty quick, especially if they'd squeeze as hard as they could. Okay? So it can cause very severe levels of pain. And while the person's working on your teeth, you can squeeze on that, and your perceptual dominance will go to your hand instead of feeling it in your teeth. And that way you can regulate it yourself. And because you're regulating the pain levels are actually controllable in your mind. And you can actually undergo some very severe processes just by being able to control things. Okay, so, and I've seen people do this. I thought it was impossible until I saw somebody actually do it. So this is what's called perceptual dominance. Pain tolerance, of course, varies. Duration of time or intensity of pain that a person will endure will come before initiation of pain response varies between individuals. Okay? Some things that would be perceived as severely uncomfortable, people would just shrug it off. Some people are more stoic than others. You can see this when you're delivering babies, the actual cultural differences between individuals. You'll see some people will be very quiet in the room, other people will be screaming, and other people will be clucking and doing different things. But you'll see these actual cultural differences that actually influence pain tolerance. Nociceptive pain is pain that's caused by normal tissue injury. And this is what you need to understand. You need to know the terminology because people will come at you with these different terms when you're taking on exams. So nociceptive pain, okay, is pain that is caused by normal tissue damage. You can have somatic nociceptive pain, which means that it's the body's pain levels. So it's muscle, skin, that's somatic, versus visceral means organ systems. Okay, visceral pain is very different than somatic pain. Okay, visceral, somatic nociceptive pain is very localized, and you can tell the person exactly where it's located at. Okay, visceral pain, on the other hand, because the visceral information is coming to 2 to 3 dermatomes and differences, the person has much more what's called non-focal, non-descriptive pain, although it's still painful, but they can't really put their finger on it. And it goes to what's called referred patterns. Okay? So even though I might have a diaphragmatic abscess, okay, the pain doesn't originate here, but it actually originates up in the shoulder. Okay? Because the afferent fibers that go along with the afferent skin is at the C2 to C4 level. Okay? It's the same level as the phrenic nerve. So the sensory afferents that are coming back are coming along the phrenic nerve, so the person refers the pain to the shoulder. Okay? You can also have non-nociceptive pain, which is neuropathic pain, which is peripheral or central, which is basically not induced by actual tissue damage, but actually by neurogenic damage. Okay? If you inject into a nerve, that's a neuropathic pain or non-nociceptive pain. Okay? If you actually cut a nerve and you cause the ganglia to form due to axonal diffuse distribution, that's also considered neuropathic pain. So it's not that you're causing pain at the skin, but you're actually causing pain due to the nerve being injured itself. Yeah. Hitting your funny bone would still be a nociceptive pain. Okay, so it'd be the first one because it is a location where you're hitting it. It's more like somebody. It has to do usually with the nerve injury itself. So it's either somebody injecting a needle into it, cutting it, or stretching the nerve too much. then that would cause a non-nociceptive pain level. The actual skin to that area would be normal looking. Okay, it would not be injured at all. Okay? Or you can have somebody who's got an amputated leg. That would be considered neuropathic pain. Okay, because even though the leg's gone, okay, the actual nerve fibers are what's injured. Okay, and now the person's having what's called neuropathic pain. And these can be central or peripheral. In other words, you can have the information being sent peripherally from the nerve that's damaged, or it could be centrally located. Okay? Central pain is the most difficult to treat because that person is perceiving pain inside the brain itself. Okay? And we can't inject any local into the brain itself. Okay? If it's nociceptive pain, neurogenic non-nociceptive pain, and you can inject the local anesthetic and inhibit that nerve signal from going back to the brain, then the pain goes away. So you can actually do different tests. If you have a person who has got an amputated leg and you want to know if it's central versus peripheral, you can put an epidural in that person, inject the local anesthetic, and cause their muscle loss completely, which means that now you've knocked out the motors. That means you've knocked out the sensories, and you should have knocked out all the sympathetics that are coming back. And if you get no pain at that point, then it's a peripherally mediated non-nociceptive pain. Okay, it's a neuropathic pain. So that's a little bit more easy to treat. Okay, versus if that person tells you my pain hasn't diminished at all, it's still a 10. And out of that, I can tell my foot is twisted around and pointing the wrong way. And that's some people that can be severely amputations due to traumatic injuries from a blast or a severe mining injury or something like that. Then you can get these central mediated pains that are very, very difficult to treat. And the only way those things work is by inhibiting the brain. So you got to give them serotonin inhibitors and all sorts of other things that you may have to think about. Acute pain is actually a protective mechanism. It alerts an individual to actually to a condition or experience that is immediately harmful to the body. The manifestations are usually fear and anxiety. Okay, so pain is actually a good thing because it stops you from doing something stupid. Okay, when people are told, well, you know, wouldn't it be nice not to have any pain receptors? Actually, it's terrible. There are children that are born without any pain receptors. Okay, you know what happens to them? They have multiple fractures, multiple deformities of their feet and hands because they don't know when to move their hands away from things that would cause them harm. So they can cause severe injury to themselves without even knowing it. Okay, so acute pain is actually very important because it keeps you from doing something stupid and hurting yourself. Okay. Now, unfortunately, one of the things that acute pain causes, it does cause severe amounts of fear and anxiety, and that can change the way you do things. Okay? It causes tachycardia, hypertension, fever, diaphoresis, dilated eyes. It basically gives you a huge sympathetic response. It can also change your outward pain behaviors. It also drives your sugar levels up. It decreases gastric acid secretion. And that's critical for you to understand because anytime anybody breaks a bone, at that point, if they have been they just ate breakfast, let's say, at 8 o'clock, and they broke their bone at 9 o'clock, guess what? That person's stomach has stopped working 1 hour after they ate. That person has a full stomach for 24 hours until the sympathetic system shuts down. Okay? If you do that person's operation 6 hours later, and you expect just because 6 hours has transgressed that the person's stomach is going to be empty, you're going to be finding out in the hard way that's not the case. That person will aspirate and die on you unless you do a rapid sequence on them. Okay, so in these kind of situations, you have to ask the question, when did you eat and when did you break your leg? If you're 6 hours difference, then you're fine. You're going to be fine. The stomach's empty at that point. Now, you may have some acid secretions that are still there, but you're not going to have a big food bowl that's just coming back up. Okay? So just remember that. Okay? There's acute pain that could be a somatic. Acute somatic arises from connective tissue, muscle, bone, skin. Okay? The alpha-delta fibers, pain is sharp and well localized. The C fibers are more dull, aching, and poorly localized. The acute visceral pain is usually in internal organs and abdomen. They're poorly localized through the lesser number of nociceptors. Okay? Then you can have what's called referred pain, the pain that represents an area removed or distant from the point of origin. The area of referred pain is supplied by the same spinal segment as the actual site. So things like myocardial infarction pain can go down the arm. Okay, in some people, they can sometimes refer to their chest or also to their upper portion of their shoulder. And that's all because this is referred pain. Shoulder pain is something we see very frequently. It's usually because laparoscopically they just insufflated a bunch of CO2 underneath the person's diaphragm, and now they've got this referred discomfort after the surgery. And usually it's associated with the shoulder, and that's because it's underneath the diaphragm that's being irritated. This is a typical referred pain patterns that you see. As you can see, the liver is the same pattern that you would see as the lungs. Okay, so if you have air underneath the diaphragm, it could be pain in the shoulders here. Okay, or you also get liver injuries or gallbladder pain. It'll be referred up here. Okay, you'll have a small intestinal pain. Will rotate different portions of the viscera. Sometimes it'll be over the umbilicus and will shift to the left or the right. The kidney pain will usually be referred to the back. Okay, which is posterior, and then as they say, a stone moves forward through the ureters, it'll be referred anteriorly in a band pattern going towards the inguinal area as the stone moves down towards the bladder. Okay, so all these are different kinds of referred pain that you can see. Chronic pain, on the other hand, is a situation or state of existence that may be sudden or developed insidiously. Chronic pain is usually referred to a pain that's lasting at least for 3 months. And their pattern, basically, response pattern varies differently in different people. And unfortunately, it produces significant behavioral and psychological changes that are really very detrimental to that patient. Mechanisms implicated in chronic pain is where we'll stop here, and we'll give you guys a 10-minute break.